Brian, as always, a pleasure. Thank you, and thanks to Helen for the invitation and an opportunity to update you on this pilot evaluation of transplant for cholangiocarcinoma. As has been said already, it's very humbling to hear the stories that are expressed, and it's quite daunting actually speaking to an audience like this. So please bear with me and hope I can answer questions as we go through. No specific disclosures. The role of transplantation really is for two groups of patients, and that's the patients with intrahepatic cholangiocarcinoma and those with perihilar cholangiocarcinoma. Distal cholangiocarcinoma is not an area that's usually accessed during transplantation, and therefore transplant isn't a viable option as a treatment for cholangiocarcinoma that arises in that area. And in the UK, there's two specific sort of subgroups of the intrahepatic and the hilar cholangiocarcinoma for where transplant is an option, and that is small intrahepatic cholangiocarcinomas and people with perihilar cholangiocarcinoma that is associated with PSC. And the situation in where liver transplant is considered is really for quite a restricted subset of patients with cholangiocarcinoma. So it's considered for people with small, early cholangiocarcinoma, so that's less than a few centimeters, a single lesion. The disease needs to be localized to the liver or the hilum of the liver. So no involvement outside that with no lymph node involvement, no invasion of nearby structures, no spread elsewhere in the body. And it's really for patients that are newly diagnosed, patients that haven't undergone surgical treatment previously. And it's not possible to, we've heard about the new therapies from John, how they can shrink the tumours, but currently it's not possible to shrink tumours such that they're within transplant criteria. They have to be always within transplant criteria to be considered for transplantation. And another important consideration is that they have to have been considered for surgical removal, surgical resection alone first. So it's really reserved for people where resection is not possible, and that's usually because of the position of the growth or the severity of the background liver disease, such that it prevents the removal of the affected part of the liver. And then after going through all those steps, people have to be well enough to have the transplant and be anticipated to have a favourable outcome after the transplant. So it's really to highlight it's quite a small subset of patients for where we would consider transplantation. And the history of this is that when transplantation was first introduced as almost a routine procedure in the early 90s, it was applied to all different kinds of conditions, including various types of cancer, even cancer that had spread to the liver. And the experience in the 90s and the really in the late 90s, when patients underwent liver transplant for cholangiocarcinoma, and there was no staging or consideration of people having limited disease. It was more, is it possible to do a transplant? What would happen if we did a transplant? And this is data that came from Leeds, and is similar to international data as well, where there were only 12 patients that underwent liver transplant in this series from across the 90s. And what you can see here is that the survival after transplant was really unfavorable. And so almost in this series, all of the patients had recurrent disease and succumbed within 5 years of transplantation. So around 2000, cholangiocarcinoma was considered an absolute contraindication to liver transplantation. And transplantation ceased for people who had cholangiocarcinoma, where it was considered that that was the disease you were doing the transplant for. But that didn't mean that transplant for cholangiocarcinoma ceased, because inadvertently, because of some of the challenges around the detection of cholangiocarcinoma, we continued to transplant some patients, about 8 to 10 patients nationally, who had cholangiocarcinoma, but it wasn't known about at the time the transplant was undertaken. And it speaks to some of the challenges of early detection of cholangiocarcinoma. These are a group of patients who would be being watched quite carefully while they were on the transplant waiting list. But even then, we weren't aware that cholangiocarcinoma was present at the time transplant was undertaken. I think there were a couple of things to highlight from this. A third of the patients had quite early disease, so what we call T1 tumours, but the majority of patients, it was quite advanced. So it speaks to that issue of the limitations of detection of cholangiocarcinoma, noting that this is a kind of historical cohort of patients. So I think the methods we have for detection are much improved now. But what you can see is that in patients that had early disease, in fact, the outcomes were really quite favourable. So there was 80% 5-year survival. And in the UK, we consider futility in relation to liver transplantation as an anticipated survival after transplantation that's worse than 50%. And the reason that we have to put such restrictions is that there's a limited number of organs that are available, and we've got a duty to use them as effectively as we can to improve the outcomes of people that need to undergo a liver transplant. But those outcomes really were quite good for people with early stage disease, and you can see the outcomes were better for the patients with intrahepatic cholangiocarcinoma compared to the ones that had perihilar cholangiocarcinoma. In the meantime, there were a lot of developments internationally, and around 2018, roughly, it was suggested that we should revisit transplant for cholangiocarcinoma in the UK, and that came to the Liver Advisory Group, which is part of NHSBT and oversees the governance and the guidelines for transplantation within the UK. And in the end, agreement was reached that a pilot for transplantation for cholangiocarcinoma should start. And the key thing to highlight is it wasn't undertaken as research. It was about trying to demonstrate that within the UK, we could replicate the outcomes that were taking place internationally in other centres around the world. So there was a whole laborious process to that. It was quite time-consuming. It occurred through COVID, so it was quite prolonged. But we got to the point where we managed to set up an implementation group, define really the criteria that would allow us to take patients to transplantation and get the program started. And thanks to Raj Prasad, who really led the endeavours of getting the implementation group going and finalising the implementation of the program. But that was also just to highlight what a multidisciplinary job it was to get the whole thing set up and get everyone on board, including PPV representation, and Helen was heavily involved in that. So there's now 2 categories of patients that we can take forward for liver transplant in the UK. As I've already mentioned, when the pilot opened in February of 2023, we were allowed to register patients where the primary tumour was up to 2 centimetres in size, which is really quite restrictive. There needed to be background of chronic liver disease, cirrhosis. It needed to be irresectable. It needed a biopsy to confirm cholangiocarcinoma was there. And then I think Tim's talking about pathology and cholangiocarcinoma, but these mixed tumours were specifically excluded. And those criteria were really copied from this publication from 2016, where it was demonstrated in quite a small number of patients that fulfilled those criteria that the outcomes after transplantation could be quite favourable. So it was around 70% 5-year survival with less than 20% risk of recurrent tumour at 5 years after transplantation. And those results are similar to some of the patients that we transplant with other cancer indications. The recruitment of patients into the pilot was quite slow, and all of the cancer indications, the new cancer indications, were revisited in 2025. And given the change in the recommendations of ESA-ILCA guidelines, after some debate, there was agreement that the criteria should be expanded to 3 centimetres, and there were some other modifications made. But really, the main change was that the lesion could be larger. It was possible to have for people to have been on treatment before, as long as it wasn't downstaging of the tumour into criteria. And it was possible to treat the growth while the patient was on the list to prevent it getting larger. And again, the cholangiocellular HCCs were excluded. So for this pathway, the patients are identified through the cancer MDT, whether that's within the transplant centre, the HPV cancer MDT, or in a non-transplant centre. They're referred for transplant or consideration of transplant through the transplant MDT, worked up for transplant, listed, and then the plan is to have them transplanted within 3 months. If they're not transplanted within 3 months, then restaging and reassessment at 3 months to ensure that they're still within criteria, and if so, they continue again to wait for another 3 months. The other group of patients where it's now possible to proceed to transplantation is patients with perihilar cholangiocarcinoma with PSC, and this pilot opened much more recently, and there's a reason for that which we can touch on as we go on. The criteria of the patients, again, it's small lesions, so there can be a mass that's less than 3 centimetres. Sometimes this is detected within the bile duct, and it extends along the bile duct, so there may not be a mass lesion as such, and there's no limit on how long along the bile duct this extends, but the lesion, if it's a mass lesion, has to be less than 3 centimetres. And for this pilot, a positive diagnosis of cholangiocarcinoma. So you need to have a clear histological diagnosis to allow transplant to proceed. And I've mentioned the exclusion criteria that were applied. So, you know, any spread, any prior treatment, any spread into the liver. And the reason for these is that this is a modification, really, of the what's called the Mayo Protocol. And this protocol that was established in Rochester, Minnesota in the early 90s. And it's the same size of tumour, the same localization to the liver, but one of the differences there was it's not necessary to have a confirmed histological diagnosis of cancer. And there was a lot of debate about that within the implementation group as to whether a firm diagnosis was required for the UK pilot, but in the US they've moved away from that. And as part of, unlike the intrahepatic cholangiocarcinoma protocol, this is much more complex, and there's a course of neoadjuvant therapy, and in the Mayo protocol, that's with external beam radiotherapy and brachytherapy. So brachytherapy is when they place a radioactive wire into the bile duct, and they give external radiotherapy at the same time. And that's not a therapy that we have available in the UK. And then after completion of the neoadjuvant therapy, they continue to receive chemotherapy while they're on the waiting list. And what the Mayo group have demonstrated is the outcomes with this approach are favourable. So this is 10-year outcomes of over 60% for all comers. They've treated 376 patients at this time, so this is 2020, through this protocol. So 376 patients started the neoadjuvant treatment, and the outcomes of those patients that were transplanted overall was favourable. But one thing that's really important to highlight, and I think is relevant to how the management of the patients through the pilot, a substantial number of patients drop out before they actually get to transplantation. And so, although you're setting out with the intent of transplantation, disappointingly, it's only about 2/3 of the patients that will get to the point where transplant takes place. And then the reason that in the UK we selected patients with a background of PSC as well as cholangiocarcinoma is you can see in this graph here, or in this image here, that the survival in blue for the patients with PSC is higher than those that don't have a background of PSC, and the risk of recurrence is lower for those patients with PSC compared to those patients that don't have PSC. So because we were wanting to tread gently into transplantation in this setting, we selected transplant for the PSC patients where the outcomes are more favourable. I'll skip over that, but that's been replicated now internationally, and one thing that's been shown is that patients who have neoadjuvant therapy, so some form of treatment before they undergo transplant, have much more favourable outcomes than patients who do not receive neoadjuvant therapy. And this has led to the development of this protocol. Now, this protocol involves giving, instead of brachytherapy, proton beam therapy as part of the neoadjuvant treatment pathway for the patients with perihilar cholangiocarcinoma. And this is a very expensive treatment. It's about $100,000 per patient. Proton beam therapy has been used to treat cholangiocarcinoma before, but not within a transplant pathway. So NHS England wanted this to be undertaken within structured as a study to evaluate its use in this pathway, such that they could make a decision at the end of it whether they would be happy to fund proton beam therapy as part of this pathway. And that's why it had to be undertaken as a study, and that's why it took much longer to get this open, because it had to go through all the steps of being opened as a clinical trial. Although, unlike some the studies John was speaking about, this is a single-arm study, so there's no randomization. Everybody goes into the pathway, has the neoadjuvant therapy, and then undergoes transplant. And this is the final slide. It's a complicated pathway. The patients are identified in the transplant centre. They are referred for PBT. They undergo 15 treatments over 3 weeks. They come back to the transplant centre. They then get reassessed, added to the waiting list if they remain within transplant criteria, have ongoing chemotherapy while they're on the list, and then get to transplantation. So it's quite a complicated journey. There's only 2 centres for PBT, which is at the Christie Hospital in Manchester and at UCL. There's 7 adult liver transplant centres, and then there's a number around 20 HPB centres. So it's really quite a complicated pathway, and it's quite an endeavour to get the patients through to the point of transplant. But this is, we're in the since October this has been open, and we've seen a number of patients recruited since then. So it's just to acknowledge everyone that's been involved. Thanks for your time. Happy to take any questions that you have.